Hi, I'm Dr. Yan. Good morning in Taiwan and good evening in United States. My pleasure to welcome all the participants who attend this meeting today, online or in person. I think this is the first conference in the history of our society which conduct on a digital platform due to COVID-19 pandemic. The theme of this training course is to learn more the interpretation of procyclovir PET for prostate cancer. For the first part, we invite two our guest speakers. The first one is Professor David Schuster. He's Professor, Department of Radiology and Imaging Science and Director, Division of Nuclear Medicine and Molecular Imaging, Emory University School of Medicine. Actually, he is an old friend of ours. He visited Taiwan in person and introduced procyclovir PET for the first time on the annual meeting of our society on November 2019, held in Tainan. Also, last year, he gave an online speech sharing more knowledge on procyclovir PET. Today, he will give us a lecture on procyclovir PET for prostate cancer, applications, and advice. The second speaker is Professor Jonathan McConaughey. He's Director, Advanced Imaging Facility, and Director and Associate Professor, Division, Molecular Image and Therapeutics, the University of Alabama at Birmingham. He will share us 10 cases of procyclovir PET. After a short break, second part, we will have 4 hospitals for young attending in Taiwan. They will share us their cases. And Dr. Schuster will give us Finally, I'd like to thank Dr. Schuster and Dr. McConaughey. And also, I'd like to thank the team of Society of Nuclear Medicine, Molecular Imaging, who helped us, the organization of this training course. Also, GMS Company for their sponsoring, which the training course a great success.
Okay, yes. Is Dr. Schuster?
Okay, Bonnie, just give me the sharing option. Going to set up the screen sharing. You could let me know if everyone can see this, I hope. Everyone can see the slides? Great. So I'm going to be talking on procyclovir PET and a little bit of a primer going over the high points. And this Emory is located in the U.S. in Atlanta in the Southeast. Disclaimers. Let's start with the case. This is a patient with a PSA of 4.9, local prostate therapies, had a negative multiparametric MR and CT for extraprostatic disease. In fact, it was noted to be unchanged from prior exams. With procyclovir imaging, we see uptake in a 7 by 4 millimeter aortic cava lymph node. It's very small, and I'm going to blow it up. It has a fatty hilum. But indeed, this was malignant on laparoscopic biopsy. Fluciclovine, otherwise known as FACBC, or the trade name of Adjuman, is a non-natural amino acid PET radiotracer. Amino acid transport is upregulated in many cancers, including prostate cancer. The most intense physiologic uptake is in the liver and pancreas, so the whole body biodistribution is different than that of FDG, though the effective dose equivalent is similar to FDG. Moderate to mild activity is seen in the salivary glands, pituitary, adrenals, and muscles, and there's more marrow heterogeneity than we see with FDG. There's mild to no brain activity as well as bladder, though in a minority of patients we can see an early excretion pattern, and I'm going to show some examples of that. There's variable activity in the esophagus, stomach, bowel, and adrenals. The LOCATE Phase 3 trial was a multi-center intention to treat trial in the US enrolling over 200 recurrent prostate cancer patients. The median PSA was 1. Detection rate varied with the PSA level from very high with higher PSAs to approximately 30 to 50% with PSA less than 1. And there was a 59% change in management post-scan. But a lot of studies have shown change in management. The question is, does it really make a difference in outcome of patient? Well, that's what the Empire 1 trial was designed to look at. We accrued 162 patients who were biochemically recurrent post-prostatectomy. They were stratified, then randomized into salvage radiotherapy based on either conventional imaging, which was MR and CT, or based on the fluciclovine scan. The primary aim was to look at 3-year PSA-free survival. Now, if we look at positivity rate, we could see that orange is fluciclovine. There was much higher positivity versus conventional imaging. And this is just an example of some images showing nodes from the fluciclovine. The radiotherapy was changed in 35% of patients. But again, did it make a difference or not? Well, we could finally say, as presented in Astro and published about 3 hours ago in The Lancet, that using fluciclovine to plan the radiotherapy made a big difference. We could see here the red is the fluciclovine arm, and the blue is the conventional imaging arm, and this is failure-free survival. So at 3 years and at 4 years, there was a better failure-free survival if you use fluciclovine to plan the radiotherapy than conventional imaging. And in fact, at 4 years, it was 75% survival versus 51%. So fluciclovine is FDA approved, and this was FDA approved in the United States for recurrent prostate cancer. And in Taiwan, it was FDA approved in July of 2020 with the same indication. Fluciclovine as well as choline are listed in the NCCN guidelines for recurrent prostate cancer. Now, a little word on PSMA and fluciclovine. And I could give a very long talk on this, but I'm going to distill it down into what I think is the bottom line. Fluciclovine and PSMA are significantly better than conventional imaging. Fluciclovine has an advantage in local detection. This is important to guide salvage therapy. There's low urinary excretion compared with most PSMA radiotracers, and there's an added advantage of being able to inject and then image right away on the table. PSMA radiotracers appear more sensitive than fluciclovine and choline for extraprostatic detection with similar high specificity. This is also important to guide salvage therapy. The differences seem greatest at lower PSA levels and in bone. So there's certainly a skill for reading fluciclovine, as you're finding out, as there is with FDG. I believe fluciclovine PET is a little more technically demanding than FDG or PSMA. It must be acquired correctly, but standard training and interpretive criteria are available. PSMA is FDA approved at only 2 locations in the US right now, but not widely available in the US. This may change by the end of the year, and PSMA is not FDA approved in Taiwan. With time, likely, PSMA will subsume fluciclovine, especially once low urinary excretion fluorinated PSMA is approved, which I think is a little further away. But fluciclovine will still be valuable for some scenarios, such as PSMA negative or equivocal disease, or even in response to therapy. Now, this leads us to the Empire 2 trial, in which we're taking the same cohort of patients who are biochemically recurrent post-prostatectomy. We're stratifying them, then we're randomizing them into arm A, that's treated based on the now standard of care fluciclovine, or arm B, which is being treated based on the findings from PSMA. We're going to be looking at 2-year failure-free survival and beyond. And this is just an example from the trial of fluciclovine and gallium PSMA positive nodes. And we're about halfway accrued on this 145 patient study. Now we're going to go to clinical imaging protocol. And there are some excellent papers available, such as the ACR ACNM practice parameters. And there's a joint EANM SNMMI procedure guideline for fluciclovine. I'm just going to give the high points for patient preparation and imaging. First, we found with use that if you can, have the patient refrain from voiding immediately before scanning. Maybe, if they can not urinate for about 30 minutes before the scan, maybe a little longer. A relatively distended bladder may mitigate that occasional early fluciclovine excretion. Of course, though, you want the patient to be comfortable in the scanner. So, just go by the patient comfort. We inject 10 millicuries as an intravenous bolus injection. Then you want to start your stopwatch. This gives you enough time to get the CT, and we would go in a cranial caudal direction. Then at 3 to 5, target 4 minutes on your stopwatch. Get the PET from the bottom up. It's important to get the PET from the bottom going up. And once your techs get a little used to doing it this way, it becomes like a dance, and they could be quite proficient in obtaining this. There's some excellent full reader training program available through the SNMMI CTN, though it's being transitioned to the Blue Earth website. And you could Google Agilent reader training, and it's free to take. But we're also going to give you training during the session. Now, as with any imaging, you should be familiar with incidental uptake and variance. This is from a different trial with breast cancer. There's a female, but we could see breast cancer lighting up. Now, while amino acid transport PET is less prone to inflammatory uptake than we see with FDG, it can still happen. And this patient has prostatitis, and there was uptake with fluciclovine. Benign prostatic hypertrophy can also be a confounder. Just as with sestimibie, the radiotracer can get a little sticky in the vein on the site of injection. Now I'm going to show you this variant bladder activity that we've sometimes seen now. So this patient has nodular activity in the posterior bladder, in the lumen, not in the wall. Now there's activity outside of the bladder in the right lateral resection margin. The MR shows very nicely, there's a nice correlation of the activity in the bed, and that is recurrence. But there is absolutely nothing abnormal in this bladder. So why does this happen? Well, if we look at dynamic MR imaging showing how gadolinium comes into the bladder, we could see that early on, gadolinium jets around, and then it looks quite ugly. It looks like a tumor. And that's what we're seeing. Sometimes you're catching a little early fluciclovine excretion, and you're just catching it kind of swirling around in the bladder. And if there's any doubt, you could just get an MR or an ultrasound. Now, image interpretation is predominantly qualitative, visual. The general guidance is to understand the patterns of spread of cancer, as you would reading any kind of study. You want to know how, in this case, prostate cancer spreads. Prostate cancer typically spreads from the inside out. You want to err on the side of specificity. Maurad L3 is a more highly specific comparator, assuming that L3 is a normal vertebral body. But with increasing experience, allowing for partial volume effects in your equipment, you could ratchet down your threshold and call additional areas of uptake suspicious with confidence, with a little bit of experience. So let's first deal with the post-prostatectomy situation. In terms of where there's recurrence, vesicourethral anastomosis is the most common area of recurrence. And sagittal images are useful to differentiate physiologic periurethral activity from abnormal uptake at the anastomosis. And I'll show you examples of that. Next come the lateral surgical margins of the seminal vesical regions. Then the retrovesicular region behind the bladder. And other local invasion is less common, such as urethra, bladder wall, and rectum. So, for post-prostatectomy, if we have focal uptake equal to or greater than bone marrow, we're talking about the prostate bed now, it's likely malignant. No focal uptake is likely benign, and focal uptake between blood pool and bone marrow, well, that's maybe your in-between place. You might call it not meeting the threshold for malignancy or equivocal, or maybe follow-up is recommended. Now, if we have a small focus in the prostate bed and it's less than 1 centimeter, you could ratchet down your threshold. And actually, we read in the prostate bed area with very high sensitivity. So maybe if it's just greater than blood pool, but getting close to bone marrow, not quite there, we can also call that suspicious for malignancy. I think MR correlation is very helpful here. And many times you have to go back to the MR after you do the fluciclovine and you realize there's something abnormal there. So this is a patient with a PSA of 0.29 post-prostatectomy. Note the periurethral activity, but there's this little hump, this lesion here that does not belong at the vesicourethral anastomosis. It's greater than bone marrow, and this is a recurrence. Now, this is a negative case. We can see here our periurethral activity. Sometimes it looks single, sometimes it's parallel. And there's no activity at the vesicourethral anastomosis. And as we go down the bladder, you can see a little bit of mild symmetric uptake in the bladder wall, but there's no activity at the lateral resection margins. So you'd call this negative. Now, this patient has a PSA of 0.16 post-prostatectomy. Note on the sagittal images, we have our periurethral activity, but there's this little focus here in the wall, just anterior to the anastomosis that doesn't belong. There's no bladder activity, okay? So this is not excreted radiotracer. So I think you could feel confident to call this positive, even though this is significantly greater than blood pool, but not really quite at marrow yet. And in fact, salvage radiotherapy was given at this location for the patient, and the patient achieved nadir. Now, sometimes we get these unusual recurrence patterns. I'm going to spin this image, and you could see here that we don't have this fine periurethral activity. This is thick and ugly looking. Now, this is not excreted radiotracer because there's no radiotracer in the bladder. So if you have something like this, you want to be suspicious about it. Indeed, this is biopsy-proven recurrence invading the urethra. And also, you know, this patient had a PSA of 10.05, so it was quite high. And so you can be even more suspicious that something unusual is happening. Let's move on to non-prostatectomy. And this is where I think it's more difficult to interpret the fluciclovine. Relapse tends to occur at the treated primary site, also external to brachytherapy seed coverage in our experience. In our original NIH-funded trial, specificity in the treated prostate was 40% with a modest positive predictive value of 75%. Most false positives are likely due to inflammation and maybe some BPH. So here you want to use a higher threshold of greater than bone marrow. Diffuse focal or multifocal uptake greater than bone marrow is likely malignant. But this really maximizes your sensitivity. If you really want to increase your specificity, well, we did a study where we were able to direct exactly where the needle went by fusing the PET with ultrasound during a truss biopsy. And we found on analysis that if you use a higher threshold, maybe twice that of marrow, you'll maximize your specificity with a modest loss of sensitivity. So really it just depends where you want to be on that sensitivity specificity continuum. No focal uptake is likely benign, and diffuse focal or multifocal uptake between blood pool and bone marrow, well, maybe that's your in-between place, and FOLP is recommended. MR may help here as well. So this is a patient who had this heterogeneous, intense uptake in the prostate, and this was biopsy-proven malignant. This patient, on the other hand, has this homogeneous, kind of boring-looking uptake in the prostate. And admittedly, this might be borderline. Maybe it's just at the level of marrow, but there's really no focality here. And this was biopsy-proven benign. Let's move on to lymph nodes. First thing you have to look at is, are the lymph nodes in a typical site of recurrence of prostate cancer? That usually happens centrally, not in the inguinal nodes, for example. That's very uncommon. The next thing you want to do is look at the maximum dimension of the lymph node. Now, this is just for the visual interpretation. The convention is to use report short axis or maybe bidimensional. But for these purpose, for visual interpretation, you're going to use that maximum dimension. In that case, uptake equal to or greater than bone marrow. And actually, if you want to increase your specificity a little bit, maybe you want to go a little hotter than bone marrow, is likely malignant. Less than or equal to blood pool is likely benign. And if it's at that in-between place, between blood pool and bone marrow, then maybe you just say follow-up is recommended. Now, if we have a small lymph node, less than 1 centimeter in maximum dimension, you could ratchet down your threshold, especially if it's in a typical site of recurrence of prostate cancer. So uptake significantly greater than blood pool, and maybe it's getting close to marrow, but not quite equal, or higher, of course, it's likely malignant. Less than blood pool is likely benign, and maybe if it's just slightly greater than blood pool, but not really close to marrow, then you could just say maybe FOLP is recommended, depending on where it is. Now, it's not just a matter of activity in relation to marrow or blood pool. There are other factors to be considered. One is location. Again, you're going to have a higher suspicion for typical areas of recurrence. So it's common to have mild to moderate symmetric uptake in the inguinal, distal external iliac, axillary, or hilar nodes. You don't want to overcall those. Shape. Round nodes are more suspicious than curvilinear nodes, especially these slit-like nodes that you see sometimes just around the acetabulum. You don't want to call those too easily. Grouping. Depending on the category, a group of nodes in a typical location is more suspicious than a solitary node, and I'm going to show you an example of that. Finally, necrosis. A necrotic node, just like with FDG, may not have very much fluciclovine uptake, so you have to be suspicious of that. So this is a patient with a rising PSA of 2.31 post-radiotherapy. MR was read as negative for extraprostatic disease. Note the intense uptake in a sub-centimeter right common iliac and obturator lymph nodes, and these were malignant on laparoscopic dissection. This is kind of the opposite. This patient had a rising PSA post-therapy. A multiparametric MR was performed and said that this node and there was another adjacent node, which were at least a centimeter, had restricted diffusion and were malignant. But on fluciclovine, there's really not much uptake there. It's pretty mild. And we really felt that this should have been hotter for its size. So we said, hey, let's biopsy this. And indeed, the biopsy was negative. This was benign. Now, these less than 5 millimeter retroperitoneal nodes, they're significantly greater than blood pool, and actually they may even be at bone marrow. They're rising up in the retroperitoneum. This is kind of a typical appearance. And if such tiny nodes have this degree of uptake, you want to consider them suspicious for prostate cancer, especially with this typical spread pattern. Now, I told you that could be some unusual spread patterns. This patient is post-radiotherapy at a PSA of 2.14 after a 5-year nadir. Notice there's uptake in the lateral bladder wall. This is in the bladder wall. This is not actually in the bladder lumen. There's also an intense left external iliac lymph node. So right away, you know this is going to be unusual, and your index of suspicion is going to be higher. This could also be bladder cancer. There was also intense uptake in the sub-centimeter bilateral inguinal nodes. Look how tiny these are, and look how intense. These are not like this mild to moderate symmetric uptake. This is really intense for its size. So we said, hey, let's go and biopsy one of these inguinal nodes. And indeed, it was positive for prostate cancer. So this is the time you want to go after an inguinal node. Finally, let's talk about bone. Because of the increased heterogeneity compared to FDG, you really want that bone lesion to pop up at you. So you want to see it on the MIP, or sometimes the coronal PET-only images or the sagittal images can help. Olytic or silent lesions are typically more intense than sclerotic lesions. So a bone abnormality visualized on CT sometimes may not have fluciclovine uptake, but it could still represent a metastasis. So slow growing, especially these dense sclerotic metastases, sometimes they may not have fluciclovine activity. In that case, you want to get alternative imaging like MR, sodium fluoride PET, or get a bone scan. But I wouldn't just stop at a planar bone scan. I would also get a SPECT CT because that's going to be more sensitive and specific. So this is a patient with post-radical prostatectomy, PSA of 1.1. Here we see on the MIP image near the end plate a focus of uptake. Now, if this were FDG, you would say, oh, that's just degenerative. But with fluciclovine, you don't typically see this degenerative uptake. Once in a while you do, but not like this. And also, if you look closely on the CT, there is a little sclerosis. Oh. We can see that here too. The MR was initially negative, but we repeated the MR, and it subsequently became positive and very obvious there was a metastasis there. Metastasis. So you want to integrate both the PET and the CT information. We've seen times when a metastasis may resemble a Schmorl's node, but you can see here there's uptake within it with fluciclovine. But this patient, look at that dense sclerosis. There's no fluciclovine uptake. This was slowly growing over time. This indeed was a metastasis without fluciclovine uptake. This patient had prostatectomy and radiotherapy, and now PSA of 10.5. Both bone scan and MR were initially read as negative. And on the CT, we could see multiple sclerotic lesions. And this commonly happens, when we're reading scans. Are these bone islands? Are these metastasis? A little bit of both, hard to say. But with fluciclovine, we could see only this pubic ramus lesion is hot on fluciclovine. These others are not hot on fluciclovine. And we were able to get a CT from 3 years before. This ramus sclerosis was new. These other scleroses were stable. So these were bone islands. This was the Met. And at the least, this can help you direct your biopsy. Now, beware this bone marrow regeneration pattern, which we see once in a while. This patient was post-radiotherapy and had now a PSA of 6.18. Now, there's biopsy-proven recurrence in the prostate, so we know about that. And I'm going to spin this image. And we could see in the right iliac bone, there is solitary uptake, and it's linear within that right iliac bone. Now, this was early in our experience, and there was no sclerosis on CT, but, we thought this was probably a metastasis. So we went and biopsied it, and indeed, the biopsy of the right iliac bone was negative. The patient went on to get a salvage surgery, and the PSA became undetectable. So this really was a false positive. And we think this is due to marrow regeneration. Sometimes you could see this in the pelvis, and sometimes you could see this in the proximal femurs. Now, this is a similar case. This is a kind of a linear activity within the ileum, and this is solitary. Patient is PSA of 4.7 post-radiotherapy. But again, you don't want to just say, oh, this is marrow regeneration, because it could be a metastasis too. So you want to follow these up, and that's the take-home message here. We recommended either an MR or a biopsy, and the biopsy was positive for metastasis in this case. Patient was treated with ADT, and look, it's healing. And there's a sclerosis there. So this indeed is a metastasis. Finally, the liver. Because of normal physiologic activity in the liver, you may not see a metastasis. So if you have a suspicious lesion in the liver, which is hypodense, but the activity is still less than liver, put a region of interest in it because it may actually be hotter than bone marrow. It just looks photopenic. So you should get further imaging such as multi-phase CT or MR. This is a patient with metastatic castration-resistant prostate cancer. Now, I can tell you that usually you don't get liver lesions until you have more advanced disease. There's supraclavicular uptake here, multiple mediastinal nodes, retroperitoneal abdominal nodes. Patient had chemotherapy. We could see the supraclavicular node get smaller, less intense, still there, but a lot of the mediastinal nodes and the abdominal retroperitoneal nodes melted away. This is just a little tail of the pancreas here. But even though the patient was getting better, in between this initial and the follow-up study, look, even on the non-contrast CT, you could see there's a hypodensity at the dome of the liver, and this is relatively photopenic. So if you see something like that, biopsy it. And this indeed was a prostate metastasis. So I want to thank you very much for your attention today. And I could take some questions now.
OK，大家现在那个就是各位线上的参与者可以提问这样。
Hello, Dr. Schuster. I'm Dr. Liu from National Taiwan University Hospital. I'm a physician. And I have a question about the case with a Gleason score of 8 with bilateral inguinal nodes activity, which one of them showed positive for malignancy. We have seen some cases with non-specific bilateral inguinal uptake. What's your opinion about this case? So yes, this case. It's not common for prostate cancer to have bilateral inguinal nodes uptake unless they have high risk before surgery or N1 before surgery. So how do you interpret such cases? Thank you.
Right. So I think let me see if I answer your question and you tell me if I did or did not answer your question. So it's unusual, right? It's like less than 5% to have spread in the inguinal nodes, okay? So I think my threshold of calling inguinal nodes is very high. And only if I see very like a high risk situation. So I knew right away that when you have a recurrence that's already hit the bladder wall and you have this intense left external iliac, and look how hot these are for their size. There's no reason for inflammation near here, okay? And therefore, we thought this was suspicious enough they should be biopsied. Now, if these were very mild, okay, and you may probably have seen already fluciclovine with very mild, I probably wouldn't have suspected them. But this was an unusual, I think, case where they actually were so intense, even though they were so subset. You could see how intense they are, that I think you really have to go after these. But normally, and then most of the time, for them to be bilateral like this, and now we didn't biopsy the left one, but I think that, you know, most likely the left one was also a prostate cancer. But I think that this is the kind of time you want to do it. Or if you see like a lot of disease and maybe it's marching out of the pelvis, you see it going out in stepwise fashion or other very maybe unusual kind of spread pattern, then I think that you want to go after it. And it's also fairly easy to biopsy. I'm going to make this full screen. I think it's very easy to biopsy a inguinal node too, if you have any questions on it. So, did that answer your question?
Thank you, Dr. Schuster. Nice presentation. I'm Dr. Huang from Taipei Medical University Hospital.
Nice to meet you.
Nice to meet you. And except for medical consideration, what kind of machine do you think, at least, what kind of level of machine you suggest? Because you know now the new modern, it's very sensitive. Especially in the delay view. You will see many false positive uptake, and we can refer it's only the non-contrast CT. So in this scenario, what is your suggestion? Thank you.
So are you talking about like what level of machine, like PET scanner?
Yeah, what kind of, because in Taiwan we have very low end and a very high end machine.
Right. Yeah. Okay.
And
so
if we use the high end PET-CT, unevolvable, the tiny uptake probably false positive or physiological uptake or something are the reasons, not real pathology. So in this situation, how to interpret it?
So, okay. So first let's talk about, the machine we use. We use a time of flight machine. And I think if you have a good machine and you tailor your uptake, your times correctly, you won't get false positives, okay? But there is a caveat here. If you're going to use resolution recovery, okay, the criteria that we developed was before resolution recovery. Then you might have uptake in the lesion greater than the marrow, just because of the nature of resolution recovery. But I would say that fluciclovine does better with better machines, such as a digital time of flight. Now, if you have an older machine, okay, such as maybe like a GEDST or something like that, I would then perhaps think about increasing your times per bed to get better images. So you have to play with it. You have to play with it because, each machine is different. And your machines from your FDG. So in general, with a lower end machine or an older machine, I would go up with the times a little bit. With the digital or, time of flight, I think you're going to get very nice images. And resolution recovery, you want to be a little careful. You may have to develop your own criteria because we don't have specific criteria yet for the resolution recovery. John, do you have anything to add to that, maybe?
No, David, I think you covered it the way I would. I would say more modern scanners do better for smaller lesions, and so that's where I think, in general, prostate cancer PET, certainly with fluciclovine, where we add the most. So I would tend to want to do it on the best scanner possible.
Dr. Schuster, there's a question in the Q&A. Will Axumin be useful for other cancers?
So that's interesting. We're studying that now. And certainly Dr. McConaughey is, one of the experts on brain. So that's one area of research, and that's how Axumin started, fluciclovine started. I have a trial hopefully starting soon, and we've reported on breast cancer. So possibly, we have a colleague in Chicago who's doing this for some gynecologic cancers. I don't think we have as definitive work as we've had with prostate cancer, but it's certainly worth exploring, especially for cancers, within the pelvis. And bladder cancer is something that we've never had a chance to really look at, but there's maybe some places that are starting to do that.
Dr. Schuster, I'm Dr. Luke, and I would like to know if delayed imaging is helpful for some equivocal lesions such as urine in ureter or bladder in the initial position. Thank you.
I'm sorry, you broke up a little bit.
Okay, I would like to know if the delay imaging, such as half an hour or 1 hour after tracer injection, will be helpful. Yeah.
Right. I don't think that long, okay, but if you have a fast scanner and so our original studies, we're using some delayed imaging. And, depending on the scanner that you have, sometimes getting like 10, 15-minute delayed images, and this has been reported in abstract form, could be helpful. So when we started with fluciclovine, we were doing this on a GE DLS camera, right? So even to get up to the diaphragm, we had to, it took us a while, and we were doing, dual time point imaging. But if you have like one of the very modern, like the whole body United scanner, or the, Siemens came out with the Quadra, it would be very interesting to get, one image at 4 to 5 minutes and then just repeat it immediately. And someone actually showed at SNMMI that you might even increase your detection rate by doing that, by doing dual time point. Again, to make it practical with the machines we had, and to do whole body, this is the way we developed our consensus criteria. But as the machines, develop more, then you may be able to, do some interesting things. At Emory, one of our hospitals, I get a delayed time point after I finished with the body. Usually there are probably about 20, 25 minutes. We don't use them for reading. We really use them for quality control. I'm very interested in how much activity went into the bladder, at a later time point. But sometimes, okay, I could tell you that if I see a lesion on that delayed imaging, and it's gotten even hotter, or it stays pretty hot, even though it's tiny, I am very, very confident that that is a true lesion. And we see that every once in a while. Now, if it fades out, I'm not going to say, oh, no, it's not, But if it stays, fairly intense, even at 20 minutes, I would, be very confident. So maybe if you have a fast scanner, after you finish the body, just for, academic purposes, if you want to get one bed position, just one, finally through the pelvis, that might be interesting. But again, I wouldn't use it as a definitive proof of anything. I think what you're doing there is, if you see a lesion, you're increasing your specificity, but small lesions are going to fade, and you may not see it. So.
David, can I add a comment to that?
Sure.
So we image some of our fluciclovine on a PET-MR scanner, and often when we do whole body plus regional imaging, we repeat the PET acquisition with the regional imaging. So we image whole body, then do a separate regional PET acquisition, in this case, obviously, the pelvis. And I will say, in many cancers that are obvious at 5 minutes, at 45 to 60 minutes, when we're often kind of collecting additional data, you can barely see them. So I do think there may be a role for delay, but many cancers, even those that are very obvious at 5 minutes, will have washout within 30 to 45 minutes.
Yeah, I agree. I wouldn't go beyond 30 minutes, And like I said, if you have a, whole body scanner, I think that's where it could be very interesting. Yeah, and I agree. At 30 to 45 minutes, you're just not going to see much. But if you can get something at 20 minutes, it might be interesting to look at. Once in a while, it might help you. But I wouldn't use that as part of your definitive criteria.
Dr. Schuster, there's one more question in Q&A. Are the liver metastases usually hot or cold?
In my experience, and when I've seen the liver metastases, they've been cold. So if something doesn't look like an obvious cyst, or, usually it's going to be a patient with advanced cancer, okay, and more metastatic cancer. I would further follow it up. So I've seen a few cases now where it looks cold. Now, cold is relative, right? So it's cold because the rest of the liver is hot, right? If you actually did a region of interest in SUV within that lesion, you'd see it's actually probably greater than bone marrow, but it just looks cold because the surrounding liver is hot. So, John, have you seen any fluciclovine liver mets that are actually hotter than liver?
No. Yeah. I've also seen incidental second malignancies, metastatic, and they're cold. Compared to liver, they're less intense.
Yeah.
Okay, thank you very much. Are there any other questions from the room? If not, we can have Dr. McConaughey start.
Wait, hello, excuse me, I'm Dr. Huang, Yasen Cancer Center. Hey, I have a question about the bladder activity. I don't have much experience. I only have 5 patients who underwent the fluciclovine exam, and 3 out of the 5 patients had bladder activity. One of them was very intense, and I am curious about what is the difference from the different patient for the bladder activity. Everyone complied with the patient preparation as the exam required, so I don't know why.
Yeah. So there are a couple things. First of all, I would investigate. You could talk to GMS, make sure that quality control is all very good. I think this is the reason why we started, if you can, okay, try to have the patient have more of a distended bladder if they can hold it. And we also had this issue when we first started using the commercial doses, okay, as opposed to our research doses. And I don't think we've ever gotten a really good answer why. But once we started having the patients try to not urinate for maybe 30 minutes before going on the table, if they can stand it, or even a little bit more, then we have less of an issue. And And now we're able to more read around it when we see it. We just know what it is. It surprised us a little at first.
Thank you.
Can I have one more question?
Uh-huh.
I'm Dr. Hu from Taipei Veterans General Hospital, and for those uptake foci fall into between blood pool and the bone marrow, the recommendation would be follow-up. So do you mean by follow-up by PET, or what's the suggested time interval?
Yeah, so I think it depends on which lesion. And so are you talking about, for example, a lymph node that you're worried about? I would follow it up maybe, prostate cancer is pretty slow growing. I might wait a few months, see if the PSA goes up, and then, maybe follow with another fluciclovine. If you still see greater activity in that node, for example, and it's gotten a little bigger, then, I think you could be fairly confident.
Mm-hmm. So like 3 months would be too short?
No, I think 3 months. I think it depends what the PSA is doing. And also you want to make sure the patient's not on androgen deprivation therapy, right? Because that's going to lower your sensitivity. But I would say it's reasonable to get another PSA in 3 months, and if it goes up, get another scan.
Okay, so it depends case by case, actually.
I think so. It's individualized.
Okay, thank you.